Hello viewers, good day to you. This is Dr. BK for you, and today I am going to talk on the back of the forearm. So the back of the forearm is also called as the extensor compartment of the forearm. So in the extensor compartment today we are going to discuss about the attachments, action and nerve supply of the muscles of the back of forearm, the nerves and vessels, their origin, course and branches of the back of forearm. Then we are going to discuss about extensor retinaculum and also the anatomy of the dorsum of hand, and finally some applied aspects. Okay, now coming to the back of forearm, like any other region, it is also covered by the deep fascia. Okay, whenever there are muscles, what happens is all the muscles, they have to be covered by the deep fascia. This deep fascia is actually thickened in the lower part as the extensor retinaculum. So the deep fascia of the forearm is actually called as the antebrachial fascia. So the antebrachial fascia is thickened in the lower part of the forearm, in the flexor compartment as the flexor retinaculum. In the extensor compartment it is thickened to form the extensor retinaculum. Now apart from that, it is going to form intermuscular septum, which is going to get attached to the radius and ulna, that is the bones of the forearm. Now in this lecture, in the next coming slides, I will be discussing about the various muscles, its origin and insertion. So again I would like to stress one point is that, so at the undergraduate level you need not memorize all these origin and insertion of these muscles. Okay, so if at all you can have an overall idea about these muscles. In the flexor compartment, I have actually discussed about the muscles originating from a common flexor origin in the medial epicondyle. Same way, the lateral epicondyle of the humerus, there is a common extensor origin from which most of the muscles of the extensor muscles of the forearm is going to take its origin, and the nerve supply of the compartment is the posterior interosseous nerve, which is the deep branch of radial nerve. Arterial supply is by posterior interosseous artery, and lower part of the back of the forearm, what happens is the anterior interosseous artery also comes to the posterior aspect and supplies the dorsal aspect of the lower part of the forearm and the wrist. So nerve is the posterior interosseous nerve, which is the deep branch of radial nerve. So that is the cross section of the forearm you are able to see here. This is your ulna and this is your radius. Flexor muscles, see, very massive muscles you are seeing here because they perform anti-gravity action. So that should be your superficial group of flexors, and then what you have is the deep group of flexors. Okay, extensor muscles, see how they are disposed. So it looks they are not exactly, flexor muscles are anterior and exactly they are posterior. This is almost anteromedial, whereas this is posterolateral. Okay, why this is? Because our upper limb rotates 90 degrees laterally during development. Okay, whereas the lower limb rotates 90 degrees medially during development. So that is why the extensor compartment of the lower limb is in the front. Okay, so during the rotation. So here the most superficial muscle in the extensor compartment you are able to see, that is the brachioradialis muscle, and it is seen even a part of it in the flexor compartment. Then you have all these muscles, the superficial group and the deep group muscles. So between the two bones, radius and ulna, you see the interosseous membrane which is extending. This interosseous membrane is also going to give origin to, mainly you are able to see the deep group muscles of the extensor compartment. The deep fascia which covers the muscle, they are not only forming septa in between the muscles, they also form intermuscular septa which is attaching to the bone. Thereby they divide the muscles into the flexor compartment and the extensor compartment. The extensor compartment muscles, they are present or arranged as two groups. So the superficial group, 7 muscles are there in the superficial group, but these are not those. There is a mixture of all the muscles which is shown in this picture. This is actually the key to this cross section you are seeing here, but not all the superficial muscles are seen in this. Same way, not all the deep muscles are seen here. So 7 superficial muscles and 5 deep muscles, which means totally 12 muscles are present in the extensor compartment or back of forearm. Superficial group of muscles, now you are able to see here all the 7 muscles, 1, 2, 3, 4, 5, 6 and 7, totally 7 muscles you are able to see here. Starting from laterally, the most lateral and superficial muscle is the brachioradialis muscle. Then you are able to see extensor carpi radialis longus and extensor carpi radialis brevis. The names are also given here. Then followed by extensor digitorum longus or extensor digitorum. Simply it is called as extensor digitorum. To the digits, that is why it is called as extensor digitorum. Then you have extensor digiti minimi to the little finger. Extensor digiti minimi. Extensor carpi ulnaris. And finally a small muscle you see here, the anconeus muscle. So the 7 muscles are actually brachioradialis, extensor carpi radialis longus and extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris and anconeus. Okay, so you should be actually well versed with the names of the muscles. At least you should be able to name the muscles, superficial group and deep group. So the first muscle you see here, the muscle of the superficial group is the brachioradialis muscle, most superficially and most appreciated on the flexor aspect. So you are seeing the front of the arm, the flexor aspect you come across this. So from the supracondylar ridge, you are able to see lateral supracondylar ridge, and from the intermuscular septum of the arm, not the forearm, and getting inserted into by a tendon into the radius just above the styloid process. So this is your styloid process. You see here just above the styloid process. We are able to see this muscle is a flexor muscle. Yes, I told you it is a weak flexor. So it is mainly responsible for the flexion of the elbow joint and most effective in the mid-prone position. Okay, you just make your hand in a mid-prone position and try to palpate the brachioradialis muscle. Okay, so above the lateral, the upper border of the radius in the mid-prone position, what you will see is when you tight your muscles, contract, you can very well appreciate the brachioradialis muscle in your own forearm. So supplied by radial nerve, again not by posterior interosseous nerve but by the radial nerve itself, which will be given in the lower part of the arm. The radial nerve actually pierces the lateral intermuscular septum and comes anteriorly. It is the lateralmost content in the cubital fossa. So that is the brachioradialis muscle for you. The next muscle next to brachioradialis, the brachioradialis has been removed. Now you are able to see these two muscles, extensor carpi radialis longus and extensor carpi radialis brevis. The first muscle is the extensor carpi radialis longus. from the lower part of the lateral supracondylar ridge and lateral intermuscular septum. So extensor carpi radialis longus and brachioradialis have almost a common origin. They are actually arising from the lower part of the arm. Insertion actually it is going to get inserted into the base of second metacarpal. Okay, so it is going to insert into the base of second metacarpal. Extensor carpi radialis longus and also next is the extensor carpi radialis brevis. They are mainly responsible for the extension and abduction of the wrist. So extension of the wrist, abduction of the wrist, it is produced by the combined action of extensor carpi radialis longus and flexor carpi radialis. Both the radialis, extensor and the flexor combined action produces abduction of the wrist. The next muscle what you see here is the extensor carpi radialis brevis from the common extensor origin, and also from a ligament on the lateral side of the elbow joint, that is the radial collateral ligament. So it arises from the radial collateral ligament and also from the common extensor origin, that is from the lateral epicondyle, and it is getting inserted by a tendon into the base of second and third metacarpal. Now brachioradialis will be there, then extensor carpi radialis longus and extensor carpi radialis brevis. How to identify these two tendons is at the lower part of the back of the forearm, especially in the lateral part, lower lateral part of the forearm, they will be crossed by two tendons, abductor pollicis longus and extensor pollicis brevis. So these two tendons belong to the deep group of extensors, not the superficial group. But how to identify these two muscles, extensor carpi radialis longus and extensor carpi radialis brevis, is by mainly if you see these two tendons crossing it obliquely, that is the abductor pollicis longus and extensor pollicis brevis. So nerve supply now onwards it is posterior interosseous nerve, which is the deep branch of the radial nerve. Again the action is same as that of extensor carpi radialis longus. So extensor carpi radialis longus and extensor carpi radialis brevis bring about the extension of the wrist. They in combination with the flexor carpi radialis bring about the abduction of the wrist. The next muscle you are seeing here is the extensor digitorum. So something like extensor digitorum, like a flexor digitorum superficialis. Here you have the extensor digitorum, again arising from the common extensor origin. So very easy to remember, common extensor origin divides into the four tendons 1, 2, 3 and 4 for the medial four fingers. Okay, medial four fingers, index finger, middle finger, ring finger and little finger. Now if you are able to see here, what happens is, this is the four tendons. There are some intertendinous connections. You are able to see these are the intertendinous connections. They are called as the vincula. Okay, they are called as the vincula. There are two vincula. One is called the vincula longa and other one is the vincula brevia. So they maintain a connection between these four tendons. They maintain connection between these four. That means any one finger cannot act independently. Okay, so that is why you try to extend one finger, for example your ring finger, then you close your ring finger and try to extend. If you hold it with your hand you can extend, but otherwise independently, for example if you try to flex one finger, then other finger also flexes to some extent, because these extensor muscles are giving some resistance, and that is through this vincula tendons. Okay, so here you are able to see these are the intertendinous connections. Okay, now after that, after crossing this at the level of metacarpal, what happens is, they travel on the dorsal surface of the proximal phalanx. As they travel, they receive the insertion of the lumbricals and interosseous by the sides. and what happens is they go and get inserted via the dorsal digital expansion. So this is actually the dorsal digital expansion. Through the dorsal digital expansion, they are going to get inserted into the proximal phalanx and the middle phalanx, okay, through the dorsal digital expansion. So extensor digitorum muscle tendons take part in the dorsal digital expansion. So we will see what is dorsal digital expansion. Before that, they bring about extension at MCP, that is metacarpophalangeal joint and interphalangeal joints. Extension at metacarpophalangeal and IP, that is the interphalangeal joints. So here you are able to see this is actually the dorsal digital expansion, or also called as the extensor expansion. Triangular in shape, formed by the tendons of extensor digitorum and joined by extensor digiti minimi for the little finger tendon, and extensor indicis also joins them. Apart from that, what happens is the extensor expansion also receives the insertion of the dorsal interosseous, okay, which is seen here, the dorsal interosseous and lumbrical muscles. So there are 4 dorsal interosseous, there are 4 lumbricals. So I told you they are joined by extensor digiti minimi and extensor indicis for the index finger and the little finger. Here you are able to see a very schematic or diagrammatic representation of the extensor expansion. First of all, you see it is the base of the expansion. This is actually called as the base of the expansion. Covers the base and sides of the metacarpophalangeal region, and it forms a hood on top of the base of the metacarpal head. So here you are able to see, so it forms a hood around the base of the metacarpal head. So this is, and this base is related to the deep transverse metacarpal ligament, okay. So here you are able to see the deep transverse metacarpal ligament will be present. So side view, if you see, you are able to see the hood which is formed by the base of the extensor expansion, which covers this extensor tendon. Now you are able to see the whole of the dorsal digital expansion. Near the base also it merges with the deep transverse metacarpal ligament. Now the angle of the base is the deep transverse metacarpal ligament is attached, and the margins give attachment to the interosseous and the lumbrical muscles. The interosseous muscle is seen on both the medial and the lateral aspect, whereas the lumbricals is seen mainly on the medial aspect. You are able to see this is lumbricals, worm shaped muscle. That is why they are actually called as lumbricals, because they resemble Ascaris lumbricoides. Okay. So what it receives the insertion of the interosseous and the lumbricals. Interosseous is seen on medial lateral aspect, but lumbricals is seen only on the medial aspect. They form something called as wing tendons. So the proximal wing is mainly formed by the interosseous, and distal wing will be formed by the lumbricals. So above proximal wing, below distal wing. Okay, proximal wing by the interosseous and distal wing by the lumbricals. So the expansion has one central slip and 2 collateral or lateral slips. The central slip is attached to the base of the proximal phalanx, and the collateral slips, they pass sideways, unite and get attached to the base of the distal phalanx. Okay, so that is the extensor expansion, which is mainly formed by the tendons of the extensor digitorum and joined by the tendons of the dorsal interosseous and lumbricals. So it has a base which forms a hood over the head of the metacarpal, and near the base it is related to the deep transverse metacarpal ligament, and receives as wing tendons the tendons of dorsal interosseous and the lumbricals. Then as you go near to these apex of this extensor expansion, it divides into one central slip and two lateral slips. Okay. Now the main function of this is extension of the metacarpophalangeal joint. Not only that, flexion of metacarpophalangeal joint and extension at the interphalangeal joint. Okay. See, through the extensor expansion, what happens is the lumbricals and interossea are also gaining insertion into the dorsal aspect. So there is actually, what happens is the balance between the extensor and the flexor muscles. When you extend your fingers, so it should not be hyperextended or it should not be flexed. This balance is mainly maintained by the extensor expansion. The next muscle which we are going to see here is the extensor digiti minimi muscle. So extensor digiti minimi again arises from the common extensor origin of the humerus. You are able to see this small tendon which is going to go to the little finger. So insertion into the dorsal digital expansion of the fifth digit. So we also see that this one with the extensor indicis is going to take part in the dorsal digital expansion. This is vincula intertendinous connections. Okay. So action of this extensor digiti minimi is extension of little finger. Insertion is into the dorsal digital expansion supplied by posterior interosseous nerve. So hereafter all muscles what I am speaking is posterior interosseous nerve except the brachioradialis and extensor carpi radialis longus. Apart from that, all the other muscles are supplied by the deep branch of the radial nerve. So the next medial most muscle what we have seen is the extensor carpi ulnaris, common extensor origin and posterior border of the ulna. In common with the flexor carpi ulnaris, because on the other side of medial side what you see is on the front, it is the flexor carpi ulnaris. Insertion into the base of the fifth metacarpal. So base of the fifth metacarpal, it is getting inserted. So extension of the wrist along with the extensor carpi radialis longus and brevis. Adduction along with flexor carpi ulnaris. So adduction. Same way this extensor carpi radialis longus and brevis bring about abduction with the flexor carpi radialis. Extensor carpi ulnaris bring about adduction when combined with the flexor carpi ulnaris. So that is about the extensor carpi ulnaris. The next last muscle of the superficial group you see here, this is the anconeus muscle, a very small muscle you see here. From the posterior aspect of the lateral condyle of the humerus, they go and get inserted into the olecranon process of ulna. So they bring about to the olecranon process of the ulna and into the upper one third of the posterior surface of the ulna. It is a very weak extensor and it is supplied by the nerve to anconeus. Okay. The nerve to anconeus also, the anconeus muscle also has some function is, so it is intimately related to the capsule of the elbow joint. Okay, so it prevents the capsule by getting pinched between the olecranon fossa and the olecranon process of ulna during the extension of the elbow joint. So it pulls the capsule, thereby the capsule does not get trapped between the olecranon process of ulna and the olecranon fossa of the humerus during extension. Now coming to the deep group. Now as I told you, the superficial group, they have a common extensor origin. Here also in the deep group, when you see, they also have a common pattern. Most of the muscles they are going to get originated from the interosseous membrane, from the deep aspect of the interosseous membrane. So first muscle definitely not from the interosseous but wraps around the one third of the shaft of the radius. Two fibers, superficial fibers and deep fibers. The radial nerve will pass between the superficial and deep fibers, and after passing it will give an additional branch to the supinator muscle. The insertion into the shaft of the lateral surface of the radius. You know, the supinator muscle is also forming the floor of the cubital fossa. So mainly brings about supination in an extended elbow. So extended elbow supination. In a flexed elbow, the powerful supinator is your biceps brachii muscle. Okay. In the flexed elbow, supination is effectively performed by the biceps brachii. In extended elbow, supinator forms the supination at the radio-ulnar joints. Next, you are able to see this muscle, the abductor pollicis longus. So, the abductor pollicis longus, posterior surface of the shaft of the radius and ulna, and also from the interosseous membrane, as I told you. From now on, you will come across this interosseous membrane. So, if you don't remember anything about this muscle, at least you can write interosseous membrane. Deep groove means, remember interosseous membrane as one of its origin. It is getting inserted into the lateral side of the base of the first metacarpal. Lateral side of the base of the first metacarpal. It abducts and extends the thumb. So, mainly it is responsible for the abduction and extends the thumb. Nerve supplies by the posterior interosseous nerve. The next muscle you are able to see here, this muscle is your extensor pollicis brevis. Again, posterior surface of shaft of radius below the origin of abductor pollicis longus and from the adjoining interosseous membrane. It is getting inserted into the dorsal surface of the base of the proximal phalanx of the thumb. So, extensor pollicis brevis into the proximal phalanx of the thumb. Action is extends the proximal phalanx. The next muscle which you are going to see is the extensor pollicis longus muscle. Extensor pollicis longus muscle arising from the posterior surface of ulna and adjoining part of the interosseous membrane, base of the distal phalanx. While the extensor pollicis brevis inserts into the base of the proximal phalanx, this goes and inserts into the base of the distal phalanx. It is responsible for extending the distal phalanx of the thumb, that is your lower part of the, or anatomical position it is lower part, otherwise the upper part of the thumb. So, what is actually hammer thumb? Hammer thumb is when there is a dislocation or fracture of the lower part of the radius. The fractured segment might go and compress the artery, the radial artery present at that region. So, because of that, what happens is rupture of this extensor pollicis longus tendon might take place. Why? Because of avascular necrosis. Okay. When the avascular necrosis takes place, lot of loss of blood supply, so the tissue dies. Avascular necrosis. It can happen in bone due to lack of blood supply, because the fractured part might compress this radial artery, compromising the blood supply below that. So, due to avascular necrosis, the tendon might get ruptured. So, what happens is the upper part of the thumb or near the distal phalanx, it is present in a flexed form, and it is actually called as the hammer thumb. The next muscle you are able to see, deep group of muscle, is the extensor indicis. So, we have seen supinator, we have seen abductor pollicis longus, then we have seen extensor pollicis longus, then we have seen extensor pollicis brevis. Now, the last muscle is the extensor indicis muscle. From the posterior surface of ulna below the origin of extensor pollicis longus and from the adjoining interosseous membrane. So, it is going to get inserted into the dorsal digital expansion after joining with the tendon of extensor digitorum. Okay, after joining with the tendon of extensor digitorum. So, through the dorsal digital expansion. So, it is mainly responsible for extending the index finger. So, we have finished with the 7 superficial muscles of the extensor compartment, followed by the 5 deep group of muscles. So the 5 deep group of muscles again I will repeat once again. They are abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis, and one muscle above which is the supinator muscle. Okay. So now coming to the anatomical snuff box. So this is actually called as anatomical snuff box. Triangular depression which is seen on the radial side of the wrist, especially when the thumb is extended. So when the thumb is extended, you can very well see the depression. It is a depression which is formed between these tendons. So these tendons form the boundaries of this box, anatomical snuff box. Medially, it is by the extensor pollicis longus. So this is the extensor pollicis longus going to the base of the distal phalanx. Then two oblique tendons you are able to see here, which crosses the extensor carpi radialis longus and extensor carpi radialis brevis. These two tendons cross those two radialis longus and brevis muscle. So they are the abductor pollicis longus and extensor pollicis brevis. Okay, so laterally it is the abductor pollicis longus and extensor pollicis brevis. The roof is formed by skin, superficial fascia, and cephalic vein running on the roof, and also superficial branch of radial nerve. Superficial branch is going to supply the cutaneous innervation for the dorsum of the hand. Floor is mainly formed by the styloid process of ulna. Okay, so it is a styloid process of the radius, not the ulna, and scaphoid and trapezium and the first metacarpal. Okay, so scaphoid, trapezium and first metacarpal and styloid process of radius, they all form the anatomical snuff box floor. Why it is called as anatomical snuff box is because so people who snuff put that in this area and then they try to inhale it. So that is why it is called as anatomical snuff box. The main content of the anatomical snuff box is the radial artery. So here we are able to see the radial artery crossing the anatomical snuff box diagonally. Okay, and then it enters the dorsum of hand, and then it is going to pass between the two heads of the dorsal interosseous, that is the first dorsal interosseous. So the boundaries is, again I will repeat, for the anatomical snuff box, medially it is the abductor extensor pollicis longus, and laterally it is the abductor pollicis longus and extensor pollicis brevis. Now I will come to one more structure, that is the extensor retinaculum. So the extensor retinaculum is a thick fibrous band which you are able to see in the extensor compartment in the lower part of the forearm. It is a modification of deep fascia, and it is not transversely present, but it is obliquely present along the dorsum of the wrist. Why it is actually present? You might wonder why you need this one is because, see, from the forearm to the wrist, all these tendons are traveling. Same way in the front, the flexor tendons are also traveling. So when you flex the wrist or extends the wrist during bending, these tendons might move out of the way, then you won't get effective flexion or extension. So that is why what happens, a band like this holds the tendon in place and thereby prevents the bowstringing of all these tendons. The attachments of the extensor retinaculum, laterally to the anterior border of the radius. So it is at a higher level and above the styloid process. Then the fibers, they pass downwards and medially, or the vice versa. You tell first the medial attachment into the pisiform and tricutral, and the fibers pass upwards and laterally to get inserted into the anterior border of radius. So to the front it is going to the anterior border of radius, obliquely placed. Are you able to understand? It cannot be transversely placed. If it is going to be placed transversely, so front you have flexor retinaculum, back you have extensor retinaculum, both almost at the same level, then it will restrict any movement of these tendons. So that is why to facilitate movement, It is actually obliquely oriented. Now, from this extensor retinaculum, you can see septa passing between them and dividing them into compartments. So, here we are able to see there are almost 6 compartments starting from lateral to medial. In the first compartment, you have abductor pollicis longus and extensor pollicis brevis. Okay, these two tendons forming the lateral boundary of the anatomical snuff box. Then in the second compartment, you have extensor carpi radialis longus and brevis. They almost travel together right from their origin. The third compartment is the extensor pollicis longus. So here you are able to see. So that is the abductor pollicis longus, then extensor pollicis carpi radialis longus and brevis. Then what you see is the extensor pollicis brevis in the third compartment. Fourth compartment is extensor digitorum, extensor indicis. Along with that, you have posterior interosseous nerve and anterior and posterior interosseous vessels. So fourth compartment is important because it is also transmitting the nerves and vessels. Okay. Fifth compartment, extensor digiti minimi, passes alone. And sixth compartment, it is the extensor carpi ulnaris, starting from lateral to medial. So here you are able to see again the extensor retinaculum, which sends septa, thereby dividing into 6 compartments: 1, 2, 3, 4, 5 and 6. First compartment, abductor pollicis longus and extensor pollicis brevis. Second compartment, extensor carpi radialis longus and brevis. Third compartment, extensor pollicis longus. Fourth compartment, extensor digitorum and extensor indicis. Fifth compartment, extensor digiti minimi, and sixth compartment is extensor carpi ulnaris. So you are able to see the orientation or transposition of these fibers of the extensor retinaculum. They are somewhat obliquely placed. So from pisiform and triquetral, they get attached to the at a higher level into the anterior border of the radius just above the styloid process. They don't have an ulnar attachment. They have an attachment only to the triquetral and pisiform. These are all the extensor digitorum tendons. This is vincula. Intertendinous connection you are able to see. Extensor digiti minimi. This is extensor pollicis longus. This side more laterally you see abductor pollicis longus and extensor pollicis brevis. These muscles are the interosseous muscles, and that is actually the hypothenar muscle which you are seeing here. So now coming to the nerve of the posterior compartment, it is the posterior interosseous nerve. So the posterior interosseous nerve is a branch from the deep branch of radial nerve. It enters by passing between the two heads of the supinator, and it is going to give branches to the extensor carpi radialis brevis and supinator muscle also. Okay. Extensor carpi radialis brevis and supinator, then emerges from the lower border of the supinator. Throughout its course, after emerging from the supinator, it is present between the superficial and deep group of muscles. So that is the deep branch which is entering between the two heads of the supinator muscle, then emerges from the supinator muscle, the deep branch, okay, of the radial nerve, and it is present between the deep group of extensors, and superficial group has been removed for you. It gives 3 short branches. The 3 short branches are to extensor digitorum, extensor digiti minimi and extensor carpi ulnaris. Digitorum, digiti minimi and ulnaris. Then long branches will again divide into medial set and a lateral set, which will supply extensor pollicis longus and indicis, then abductor pollicis longus and extensor pollicis brevis. Okay. So these are the branches which is supplied by the deep branch of ulnar nerve, which is the posterior interosseous nerve, and ultimately what happens, it will form a pseudoganglion, runs on the interosseous membrane and presents a pseudoganglion. From the pseudoganglion, it will supply articular branches to the wrist joint, to the inferior radio-ulnar joints. Okay. So coming to the applied anatomy of the posterior interosseous nerve, what you see here is the wrist drop. What is wrist drop? If the deep branch of the radial nerve is damaged, then all the extensors paralyzed, they are inactive. So unopposed flexor action. So because of the unopposed action from the extensor, the flexors, they flex the wrist and your wrist drops, and that is why it is called as wrist drop, due to the injury to the deep branch of radial nerve, that is the posterior interosseous nerve. Okay. So paralysis of deep extensors, so wrist hangs due to unopposed action of the flexors. Also there is a sensory loss here on the small surface on the dorsum of the hand. Next, coming to the artery of the posterior compartment, which is the posterior interosseous artery. The posterior interosseous artery is actually a branch from the common interosseous artery. Okay, one of the terminal branches of the common interosseous. The other branch is the anterior interosseous artery. Anterior interosseous artery from the common interosseous. That is the posterior interosseous. So it is going to enter the posterior compartment in the gap between the upper border of interosseous membrane and the oblique cord, which we have seen in the radio-ulnar joint, superior radio-ulnar joint. So gap between the oblique cord and the upper border of the interosseous membrane, it passes to the posterior compartment. Then it is present between the superficial and the deep group of muscles. So posterior interosseous artery, it is present between the superficial and deep extensor groups. And finally it ends in the dorsal carpal arch. So here you are able to see this is the dorsal carpal arch. It is mainly formed by the branch from the anterior interosseous artery that also comes to the posterior compartment. When it comes through an opening in the lower part of the interosseous membrane, from the anterior compartment will come to the posterior compartment, anterior interosseous artery, joined with the posterior interosseous artery, and branches from the dorsal carpal branches of radial and ulnar artery. Dorsal carpal branches. This is the dorsal carpal branch of radial artery. This is the dorsal carpal branch of ulnar artery. Then you have branches from the anterior and posterior interosseous artery. They will form this arch, which is actually called as the dorsal carpal arch. So we finished with the dorsum of the hand. Now coming to the dorsum of the forearm. Now coming to the dorsum of the hand. Mainly deep to skin, you see the dorsal venous network. Arteries, this is the first dorsal metacarpal artery. You will see the dorsal metacarpal arteries. Then dorsal metacarpal arteries to the second, third and fourth digit from the dorsal carpal arch. Then cutaneous innervation. So extensor tendons we have already seen. Dorsal interosseous muscle, we will see it in the intrinsic muscles of the hand. So branches from the dorsal carpal arch, you see second, third and fourth dorsal metacarpal arteries. Apart from that, you have the first dorsal metacarpal artery. So dorsal venous network is mainly formed by the dorsal digital veins from either side of the digits. These dorsal digital veins, they unite, proper dorsal digital veins, they form the dorsal metacarpal veins. So these dorsal metacarpal veins of the second, third and fourth digit, they unite to form the dorsal venous arch. Okay. Now the lateral part of the dorsal venous arch will be joined by the dorsal metacarpal vein from the radial side of the thumb to form the cephalic vein. When the dorsal venous network is joined by the dorsal metacarpal vein from the little finger, medial side of little finger, that will form the basilic vein. Okay. So that is the formation of the dorsal venous network, and from which on the lateral part of the dorsal venous arch joined by the dorsal metacarpal vein of the radial side of the thumb, you have the cephalic vein formation. The basilic vein is formed by the medial part of the dorsal venous arch and dorsal metacarpal vein from the medial side of the little finger joined to form the basilic vein. Sensory innervation of the dorsum of the hand. The radial nerve mainly supplies the skin over the dorsum of the hand and also to the lateral 3½ digits, but not the region of the distal phalanx or the nail bed. So that is taken care of by the median nerve. Whereas with respect to the medial 1½ fingers, the medial side of dorsum of hand and the medial 1½ fingers up to the distal phalanx is mainly taken care of by the dorsal cutaneous branch of the ulnar nerve. So the dorsal cutaneous branch of the ulnar nerve supplies medial 1½ fingers. The lateral 3½ fingers is supplied by the dorsal cutaneous branch or the superficial branch of the radial nerve only up till the middle phalanx. The distal phalanx and the nail bed region is mainly supplied by the median nerve. Okay, so apart from the extensor tendons of the dorsal aspect, you see this dorsal interosseous. We will come to this dorsal interosseous in the intrinsic muscles of the hand. Okay, so radial nerve 3½ fingers excluding the nail bed region. Ulnar nerve medial 3½ fingers, dorsum of the hand. Nail bed region of the dorsum of the hand is cutaneous innervation is by the median nerve. So thank you very much for listening to this lecture on the extensor compartment of forearm and dorsum of the hand. We will meet again in one more lecture.